Hello everyone and welcome to the Common Eye Conditions webinar, which is part of the Royal College of General Practitioners Clinical Priority Programme for Health. First of all, I'd like to introduce myself. I'm Dr. Waqar Shah. I'm the Royal College of GP's Clinical Champion for Eye Health, and I will be acting as the organizer of today's webinar, and I'm one of the initial presenters. I'm really pleased to be joined today by Ms. Seema Verma. She's a consultant ophthalmic surgeon and she works out of Moorfields Eye Hospital. I'll let Seema introduce herself in more detail shortly. Now, before we begin, I would like to outline a little bit of housekeeping for the webinar. Firstly, can I ask that throughout the webinar, we make sure that everyone's microphones are muted. If you're having any technical problems, please type in your questions in the chat box, and one of my colleagues will be here to help you on that. And at the end of our presentations, there will be an opportunity to ask further questions. Please type in your questions in the question and answer box on the right-hand side of the screen, and we'll try and answer as many of these questions as possible. If you think of any questions during the presentations, please ask them in the question and answer box, and we will also answer these at the end of our presentation as well. So finally, in terms of timings, I'll be presenting first on one common eye condition, and then I'll hand over to my colleague Seema to continue with her presentation. So the agenda is as follows, and you can see on your screen, we're going to talk about the Clinical Priority for Eye Health program. It'll just be a brief introduction to that, and then we'll move on to the meat of our presentation, which is the common eye conditions, and then there'll be a question and answer session towards the end. Why is eye health a priority for GPs? Well, it's a big priority because there are, at the moment, 2 million people walking around in the United Kingdom living with sight loss. And this is only set to increase to 4 million people by the year 2050. And of course, we know the reasons for that. The reasons are that our population is aging and there's increasing multi-morbidity that we face as general practitioners. There's also the fact is that sight loss occurs more in older people, and 80% of sight loss occurs in people over the age of 60, and we as GPs are seeing more and more patients with an elderly demographic. Now, I don't know if you know, but eye health accounts for 4.5 million consultations with GPs every year. That's a lot of consultations that GPs face with eye problems as the main presenting complaint. And I don't know if you know, but there are 6.5 million outpatient appointments for ophthalmologists to see as well. So you can see the scale of the issue is vast, and therefore eye health is a big priority, I think, for general practitioners. We do know that undetected eye conditions can have a significant impact on the individual's health and well-being. And we know that poor sight is linked to having had a stroke. Poor sight is linked with diabetes. We know that our patients regularly go to the diabetic eye screening program, and retinopathy is picked up and treated during that process. We also know through bitter experience that a lot of falls amongst our patients occur as a result of poor sight, and poor sight is associated with dementia. Poor sight also leads to high rates of depression and social isolation in our patients, and therefore eye health is an important consideration, considering that we are dealing with eye health directly or indirectly nearly every single day. So the Royal College of General Practitioners established a priority program for eye health, and this is a 3-year program to try and improve the awareness amongst general practitioners on the issues that are important, so that GPs can, to some extent, added value in their consultations with their patients. Now, we undertook a survey in 2013. Now, admittedly, it wasn't the most rigorous academic survey, but nonetheless, it told us very interesting things. It showed that the confidence amongst general practitioners in diagnosing eye conditions was not very high. There was limited awareness in terms of knowing the symptoms and signs for macular degeneration. And I think less than half of general practitioners who were surveyed felt confident in diagnosing macular degeneration. We also looked at what sort of services practices offered their patients, and less than half practices surveyed provided information in accessible format to patients. So, for example, providing information in large font wasn't really something that we found practices were providing in all cases where patients needed that, and only less than 50% of patients actually did that. We also found that amongst general practitioners and practice staff that there was limited awareness of issues affecting minority groups and patients with learning disability. But the most pressing and poignant finding from our survey was that GPs were clamoring for more information. They strongly expressed a preference for further training and support and information. And we hope that our webinar program and our program of workshops will have to help to address some of those shortcomings. We have established an iHealth network where over 500 GPs have joined from across the United Kingdom. I think this is the first time that anyone has actually established a network before, solely dedicated to iHealth amongst general practitioners. By joining the network, and you can see how you can join by the links on the slide here, you can receive regular newsletters from the network organizers, and also we produce clinical fact sheets on different eye conditions and other key eye resources, and we tend to send out a different fact sheet with every newsletter. So being a part of a network doesn't commit you to anything, but it does allow you to receive up-to-date clinical information on eye conditions with each newsletter. So you can sign up by going to circ@rcgp.org.uk or going to the UK Vision Strategy website, which is www.ukvisionstrategy.org.uk/GP network. And so far, the clinical fact sheets have included a number of very common eye conditions. So we've produced a fact sheet on infective conjunctivitis, we've produced one on dry eyes, glaucoma, Charles-Bonnet syndrome, and management of cataract in primary care. As part of the Royal College of General Practitioners Clinical Priority for Eye Health, we've actually produced a really valuable resource, in my opinion. This is a guide called Sight Loss in Older People, the Essential Guide for General Practice. I really urge you to have a look at this guide. It's written by a GP, or a GP registrar in fact. It's written by an ophthalmologist and it's written by an optometrist. So it really encompasses joined up working across different eye health professionals and primary care professionals. So it's an example of cross-sector working, and it's a very good example in my opinion. Thomas Pocklington Trust kindly supported the provision of the printing and distribution of this guide, and it has been accredited by the Royal College of General Practitioners, and Maureen Baker, the chair of the RCGP, has written a foreword to this guide. It has been sent to every GP practice and walk-in centre across the United Kingdom, so we're looking at 11,000 plus centres who have received this guide by post, and you can see the guide as a web-based entry on the ukvisionstrategy.org.uk website. I would urge you to have a look at that because, for one thing, it's very informative, and I think it will provide a lot of pointers for GPs. Some quick wins. GPs can use some of the learning in this program, in this guide, to inform their practice on a day-to-day basis. And as I said, there are some simple things that GPs can do which actually impact very massively on the care of patients. So please take a look at that. And also I think it's something we can write up as a PDP item on our annual appraisal, and it is something that we can write up as a learning activity for our annual appraisal as well. So I think it ticks a lot of boxes in one go. So now I'm going to start off by talking about common eye conditions and how to manage them. I'm only going to talk about one eye condition myself, and then I'll hand over to my colleague, Ms. Seema Verma, who will take over and go through a number of other eye conditions. So with your permission, I'd like to talk about a condition called Charles-Bonnet syndrome. Now, some of you may say, well, what is Charles-Bonnet syndrome? I've never heard of it before. I'd like to talk to you about this condition. I think all of us, probably as GPs and as healthcare professionals, have come across this syndrome, knowingly or unknowingly. Charles-Bonnet was a lawyer in living in Geneva, and he noticed his grandfather having visual hallucinations. Now, his grandfather was a very eminent magistrate in Geneva, and he was well respected and well trusted. And his grandfather lived to be a ripe old age. And Charles Bonnet knew that his grandfather, called Charles Lulin, was of sound mind. And he had no concerns about any dementia features or any other features of psychiatric illness. There was no worries there. However, this grandfather complained of these amazing hallucinations. He used to see gargoyles sometimes in the evenings. He used to see things flowing, the trees blowing in the wind in his bedroom. He used to see, when he looked out of the window down the street, there was a well there, and he used to see footmen dressed in grey uniform come out of the well and scurry down the street. And he would write down these hallucinations. He would actually enjoy these hallucinations, bizarrely, and he would talk to his grandson about these hallucinations. And his grandson, Charles Bonnet, wondered what this was all about. And he found that when the light increased, these images tended to disappear. So he first described these hallucinations, and I presented on the slide a sort of a scientific criteria for what Charles Bonnet syndrome is. There are three criteria here: the presence of formed, complex, persistent, or repetitive visual hallucinations in the absence of any other problems, namely psychiatric issues or dementia issues. Charles Bonnet syndrome is really common in people with macular problems, macular degeneration for various causes, through age-related macular degeneration, through retinopathy as a result of diabetes. Any problem that causes the retina to degenerate can give rise to these delusions. And according to the study you read, the prevalence ranges from 0.4 to 14%. So it's actually a very common condition. And what happens essentially is that these patients experience these visual hallucinations, often of children playing at the foot of the bed, or some things spinning in the air, like planets going around an orbit. The various hallucinations, gargoyles are frequently seen. And these images are not really there, but they're hallucinations. But patients actually don't mention these to their GPs. And the reason they don't mention it is because they're petrified of being labelled as being demented, or being petrified of being labelled as having psychiatric problems. And it causes enormous embarrassment, enormous alarm, distress, and fear. And the one thing that GPs can do is actually reassure patients. I can give you an anecdote of one of my patients who has macular degeneration, and I spontaneously and opportunistically asked her about the presence of any visual hallucinations. And her eyes lit up when I asked that question. It was spontaneous. She hadn't volunteered any information about this. And she said, "What do you mean?" And I said, "Well, some people with macular degeneration have symptoms of visual hallucinations." And the relief came, the wave of relief came over her face. It was actually quite striking, and it's stayed with me ever since. And she said, "You know what? No one has ever talked to me about this ever before. And by knowing that I'm actually normal, because this is a normal finding of people, in some people with macular degeneration, it reassured her so much." Now, there was nothing as a GP that I could do that could actually make the hallucinations go away for her. However, the reassurance I gave her that it was normal really was a life-changing thing for her. And after that, she really changed, and she became so relaxed about things. She wasn't worried about fears of being labelled as being mad. And her life, actually, I can say with hand on heart, changed dramatically after that very simple encounter that we had in the surgery. That consultation stayed with me ever since now. And I would say that if GPs were to proactively ask for these symptoms, we may get a lot of patients who actually admit to it. And you know what? By reassuring these patients that this is a normal feature, you can actually change their lives, because you will actually remove distress and fear from their lives, and they will live their lives more wholesomely. So I found that a very, very poignant example of what how a very simple sentence we can say to patients can make an enormous difference to their lives. So that is Charles Bonnet syndrome, and I hope that I was able to explain that in some detail. And I hope that we can actually proactively ask our patients when we have an opportunity to do so. And I think we can make a big difference to our patients' lives simply by saying to them, it's okay, this is normal, try not to worry about it. And I am sure that you will get a hug from one or two of your patients from the relief that you will provide them. So that's one condition that I've talked about. So if I now hand over to Ms. Seema Verma, she's an eminent consultant ophthalmic surgeon, and she works at Moorfields Eye Hospital, which arguably is one of the leading eye hospitals in the UK. I'll ask her to introduce herself to you, and then she will talk about common eye conditions.
Thank you very much, Waqar. Hello and good evening, ladies and gentlemen. I've been asked to talk about a couple of conditions, and I will take you through them. Just to let you have a little bit of an introduction about myself. I'm a consultant at Moorfields. I specialize in cataracts, but I also head the A&E department at Moorfields Eye Hospital, and I've been doing a similar job to some of you, because I too see lots of conjunctivitis and dry eyes and many of the conditions that you probably see. And so Waqar has asked me to talk about a few of them, and I will try and take you through them. So the things that I've been asked to talk about are blepharitis, dry eyes, and I have to say that this is a misnomer, because actually dry eyes is actually quite rare, and what most of us see is discomfort of eyes related to a poor tear film, and I'll come to that a bit more. Waqar has also asked me to talk about chalazion and cataract, so I'll take you in turn through these. Just a little bit of introduction to the anatomy of the eye, and in front of you you'll see a diagram which shows you where the lacrimal gland is. So the lacrimal gland is positioned on the lateral aspect of the orbit and is the place that produces the tears. And then you'll see that you've got the canaliculi and the puncta from the upper and the lower lid, which drains tear into the tear sac and then into the nose. And then, of course, surrounding the eyeball itself is the eyelid, which contains the lashes and the meibomian glands. If you look at a patient and look at the lid margin, you'll see on your picture that the lid shows where the lashes are, and then towards the eyeball, where the arrows are pointing, are the outlets of the meibomian gland, which produces the oily secretion, which then forms a evaporative barrier to the tear film, so that the tear film remains on the eyeball until the next blink. And so when we talk about dry eyes, actually it's not dry, it's just the tear film is not of a poor quality. Dry eyes due to Sjogren's syndrome is actually quite rare, anyway, for us to see. Blepharitis can occur because of dysfunction of meibomian gland, because they become blocked, or the tear secretion, oily secretion is very thick, or it can occur because of staphylococcal disease of the lashes. And in front of you, you'll see some lashes which are matted with dandruff-like material. And this provides a fantastic ground for bacteria to become quite active. And so both of these conditions can lead to the tear film becoming poor, or giving a chronic low-grade inflammation of the eyes, which then leads your patients to come with either an eye which is uncomfortable, which is gritty, foreign body sensation, and of course a repeated condition, for a long term, will then cause the eye to become red. And in front of you can just see an eye with quite a lot of mucus, which has been stained here with rose bengal. And sometimes, of course, you can see that the lashes begin to be lost from the lid margin. You can see the contour of the lid is slightly deformed, it's thickened, it looks red, and of course the eye is red as well because of this chronic low-grade inflammation. And so you may have patients that come with this. And I'm sure you're all aware that you can get blepharitis with skin conditions like acne rosacea. And so if you have patients that have acne rosacea, they may present as a presenting feature of their disease with symptoms of foreign body sensation. So quite a common scenario. And as I've said to you, blepharitis can be due to staphylococcal or seborrheic lid margin disease, or it can be due to meibomian gland plugging, or of course a combination. And the way that we treat these patients is with lid hygiene. And what you're trying to do is you're either unblocking the meibomian gland or you're getting rid of the staphylococcal colonies around the lashes. And so lid hygiene includes warmth to the lids. It involves massage of the lids and then cleaning. And there's a lot of stuff like, baby shampoo, bicarbonated soda, all this stuff. And there's a lot of stuff on the market to clean lids, but sometimes just warm water is enough on a cotton bud. And then we give them some chloramphenicol just to reduce the bacterial amount. And what is important is to explain to the patients that actually this is a condition that is chronic and may not be got rid of, but we can reduce their symptoms by helping them with lid hygiene and then giving them lubricants. One of the things that arises from blepharitis, as you will all be aware, is a chalazion. And here's a picture of a chalazion that many of you will have seen. And this is not what some people call a stye. A stye is a lash follicle inflammation and infection. A chalazion is several meibomian glands which have become blocked, and for want of a better word, you've got a zit on your eyelid, basically. And here's another one on the upper lid. And again, it's in the tarsal plate. The lump is in the tarsal plate. And this is basically initially treated with hot compress and antibiotic, and sometimes, of course, oral antibiotic. A broad spectrum, something like Augmentin, would be helpful. Now, most of these will settle. However, some will settle but may be left with a lump, which is unsightly, and some will go on to developing an abscess. And so either way, some of these chalazions need to be removed. And so after perhaps a month or 6 weeks of treatment with hot compress, you're left with a lump that the patient finds unsightly. Then you can curette them, so you can incise them and curette them. And for that, we use a local anesthetic, lignocaine, with some adrenaline. So 2% lignocaine with adrenaline. You would infiltrate the lid. And then I'll show you, we use a chalazion clamp and a scalpel to incise the chalazion. And then we use a curette to try and curette out as much of the pus in that chalazion. And then we give the patient chloramphenicol ointment, which we instill in the eye, and we double pad the eye because, as you know, the face is very well fed by blood vessels, and it will bleed, so it needs a good firm pad, and then the patient goes home with the chloramphenicol ointment that they use 3 or 4 times a day for about a week. Of course, as I said, this may need to be done if we find that there's an abscess, so that chalazion has an abscess, that will need to be drained pretty smartly. So this is what the eye clamp looks like for a chalazion, and you'll see that it has a little dial which you can then dial down and clamp the lid with the chalazion. So on the next screen you'll see how the clamp is used, and of course it gives you homeostasis as well, because the pressure will help with homeostasis. And there's your scalpel, and the cut that you make has to be vertical. It must not be horizontal, it must be vertical, because the meibomian glands lie vertically. And of course you mustn't breach the lid margin. So it's one of those incisions that you put in and you see pus come out straight away. And here's another one that you can see. The chalazion has a pointing head there on the conjunctival tarsal surface. And here's one in a child, which obviously needs a general anesthetic, because no child is going to stay still for you. So it'll need general anesthetic, and there's a curette that you can see that is curetting out the contents of the chalazion, because it's almost encysted, so you need to just break the loculations. So I hope that's been helpful on blepharitis. And I'm going to now talk about cataracts. Cataract, as you all know, is mostly due to aging, but of course we see cataracts right down from children through to adults. And there are a number of reasons why patients develop cataracts, but for the purposes of this presentation, we're talking about patients who develop cataracts as they're aging. And it's a very common condition. We have an aging population, so the numbers are increasing. It's the commonest operation performed in the UK, over 350,000 operations annually, and it is a highly successful operation. 95% of patients perceive better vision. However, it has to be remembered that it is also potentially an operation that can lead to blindness from either an infection, so there's a 1 in 1,000 chance that you can get an infection, an endophthalmitis, and there are complications. If the operation is not performed successfully, then there are repercussions to this. Here is a cataract that perhaps even if you didn't have a slit lamp, you would notice that the pupil is white. And we hope that less and less of our patients present at this stage, because by now this patient is seeing only light. And so we would hope that patients present much earlier to us than when they can't see at all. But here you can see the lens sits behind the iris, and here you see a dilated pupil. The patient has been dilated here, and you can see the cataract. Cataracts can come in different forms. There are nuclear cataracts, there are cortical cataracts, there are posterior subcapsular cataracts. There are many types of cataracts, and the symptoms will vary. So here somebody would have presented because their vision has gradually got worse, and all of a sudden, they're not able to do their daily activities of life, and it's been a gradual decline, and they haven't noticed anything until right at the end when both eyes are not able to see. Here's another white cataract. So this is a cortical cataract. We see patients like this, diabetic patients, can present with cortical cataracts, and of course diabetes will cause their cataract to form earlier than if they weren't a diabetic. Now here's a cataract which is a posterior subcapsular cataract, and here patients can present quite early because this type of cataract affects vision quite quickly. And it is associated again with diabetes. It can be associated with steroid use, and patients complain of glare, difficulty with driving. Sunlight causes them to have photophobia. And so, as I said, different types of cataracts give you different types of symptoms. Here's another cataract that you can see. This is a cortical cataract. You can see the white spokes. And usually, you can't see this quite clearly here, but it's associated also with a nuclear sclerotic element here. But again, patient will just say they're having problems with driving or reading. They've been to their optician. The optician can't improve their vision with glasses, and they need to come and have an operation. Now, like I said, cataracts is a common eye condition. It affects your vision, and the time to do cataract surgery is dependent on the patient. If you have a patient that perhaps drives for their living, they might require the operation much earlier than, say, somebody who is leading a more sedentary life. And so the level of vision and the time of surgery is really something that needs to be discussed with each patient. And the time for surgery is when their daily activities of life or their quality of life is affected. For driving, as you know, the level that is required by the DVLA is around 610. Now, we don't have a chart that gives us a 610 vision. The Snellen chart is 612. So anybody who has vision worse than 612 in both eyes is below the requirement, the legal requirement for driving. Of course, if one eye is better than that, then of course they are legal for driving. It's when both eyes fall below 612 that really driving is difficult. And you'll find a lot of patients may have good vision during the day, but their night time vision, they say they've got photophobia or they've got glare and can't drive. So it's also, you know, we have to be responsible citizens, and we have to say, you know, I don't feel safe for driving. And as the vision goes down, then of course you have the increased incidence of falls, and you know, in our elderly population, fractures of the femur are there because they can't see. They then fall, and then they're in bed as a result of this. So the morbidity from falls is quite high, and therefore cataract assessment in elderly patients is very important. And as Waqar mentioned earlier, people who can't see become isolated, they become depressed, and all these things are preventable if we look at what their visual function is. A lot of patients will go to their optometrist initially when they have problems with vision. A number of them will discuss the vision with their optometrist, and some of them will be given new glasses which makes their vision better, and so they don't land up in our hospital service for consideration of cataract. But even now, despite a number of patients being deflected by optometrists, I regularly in my clinic will have patients that come and say, I went to my optician, I was told that I had a cataract, and here I am. And the first question I ask them is, how is your vision affecting your quality of life? Can you do all the things that you require to do? For example, driving, reading, watching television, playing golf, whatever they do. And many of them will say, I don't have a problem. And of course, after, a full examination, we then decide that actually there's no need to do anything because they haven't got a problem. And why, fix something which is not broken? And so we give them advice that they should go back to the optician, have regular checks, and when their vision falls to a level where they start to have problems, that's the time to come back to us. And then, of course, we talk about surgery. And as I've said to you, 95% of the time, operations go well. There are conditions that make cataract surgery difficult. There are a number of conditions that cause cataracts to develop earlier. And all these things are obviously taken into account while we're discussing the pros and cons of surgery. But the most important thing to say is there's a 1 in 1,000 chance that they could have a serious complications, such as infection, such as hemorrhage, that can lead them to have worse vision than they started off with, or in the worst case scenario, no vision.
Great, thank you very much, Seema. That's very informative and very clear once again. I would like to thank everyone for attending today's webinar. All our listeners and viewers, you've been very welcomed, and thank you very much for taking part. I'd like to give a warm thank you to my colleague Seema for coming to speak to us and to the RCGP about common eye conditions. I would like to thank the RCGP and the UK Vision Strategy and Simply Health for helping to support and organise this webinar. You will be sent a feedback form after the event, and we would be grateful if you could fill it in. This was a pilot webinar, and any feedback that you would provide, I'm sure, would be very helpful in shaping our future webinar program. You can find more about the RCGP Clinical Priority for Eye Health on the UK Vision Strategy website, and that's at www.ukvisionstrategy.org.uk. And finally, I would strongly recommend that you join the Eye Health Network if you can, if you haven't already done so, because there's a lot of useful information for GPs and their practice staff and other people who are interested in primary care provision of eye health services. The information on how to join this network is also on the UK Vision Strategy website. So once again, thank you so much for attending, and goodbye for now.